So let's talk about the day of the procedure. The patient comes in. Obviously, you've educated them on what to expect. How do you approach these cases? Do you know, I'm just going to coil today, or I may coil and stent today, or are you going to stage it?
Yeah, and it kind of depends a bit on what you know from the patient's history and what you know about their imaging. So there are going to be some where you enter the room and you know confidently there's no obstructive lesion in this patient. It's all reflux, and we're going to deal with the reflux. And then there are other patients that you know the opposite. And then there are going to be a fraction of patients where there's a little bit of uncertainty and a small fraction where you really don't know, and you may end up most of the time we end up staging the treatments. Some make the argument that maybe you should just do it both, but I do think embolization has a longer track record and carries potentially less long-term potential risk to the patient. We certainly know stents perform very well from the data that's been collected for patients with lower extremity venous disorders, and the stents in the non-thrombotic patients have very high patencies. But there are some patients who get into a good cycle of having problems with their common iliac vein stents. And so you don't find as many sort of associated downsides with embolization. There are reported cases where patients think their coils are the cause of persistent pain, and coils are being removed by surgeons around the world for that specific issue. So we should keep that in mind as we see patients after we treat patients. And also you'll see patients coming in with internet backgrounds, going to support group sites. And this was a very popular conversation a few months ago on the pelvic sort of support group, pelvic pain support group on Facebook. And so, but I think the embolization as a rule is the safer thing to do long-term for the patient. And so I think with stenting, really think long and hard about who you're going to stent. And I really wouldn't stent somebody with a 50% diameter obstruction who also has reflux. And I would kind of reserve stenting for patients with more severe forms of obstruction who sort of fit into some of those groups we talked about where it makes more sense to stent.